Hello, and thank you for joining today's webinar on solutions to increase youth HPV immunization in Canada, a national quality improvement project. This is the final webinar of our four-part webinar series with Immunize Canada in 2021. It has been a pleasure to be collaborating with Immunize Canada again to host another four-part webinar series on the topic of immunizations during the SARS-CoV-2 pandemic. To find out more about our past webinars, please visit our website at canmex.ca/join Immunize Canada and CanMex webinar series, as indicated in the link you see on the screen. My name is Aishwarya Shah, and I'm a project officer for CanMex at the Canadian Public Health Association, and I will be the moderator for today's webinar. Before we begin, we want to acknowledge that the offices of Immunize Canada and CanMex, which are part of the Canadian Public Health Association, are situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been our guardians of this land for millennia, and we are grateful for the example their stewardship provides. Immunize Canada, CanMex, and CPAC are committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. So as for a bit of housekeeping, it should be noted that all attendees are muted. For this webinar, the Q&A feature located on your toolbar will be used to ask questions. If you have questions, please type them in the Q&A box. You can do so at any point during the webinar. Only you, myself, and the presenter can see your questions in the My Questions section. When asking a question to the presenter, the question is first read out loud, answered live by the presenter, and then posted in the All Questions section. If you have questions regarding technical difficulties, please contact canmex@cpha.ca and we will reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live via broadcast message in the chat. So before we begin, we have two quick notes. Firstly, this webinar is being recorded and will be made available on Immunize Canada's YouTube channel and on canmex.ca. Presentation slides will also be shared. Secondly, we invite you to take a short 5-minute post-evaluation survey at the end to provide your feedback in the delivery of this webinar. And so with that, let's begin. We have the pleasure of welcoming Dr. Thilina Bandara and Mika Rathwell to present today's webinar. Our first speaker, Dr. Thilina Bandara, is the Assistant Director of the Urban Public Health Network, an organization of senior medical officers of health from the 23 large cities across Canada. He's a population and public health researcher and the lead on the CPAC-funded project focused on improving HPV immunization rates. Our second speaker is Mika Rathwell. She's a project officer for the Urban Public Health Network CPAC-funded project on barriers to HPV immunization. She's a medical anthropologist and interested in the area of health equity. And with that being said, I would like to turn it over to Dr. Bandara to begin the presentation.
Thanks everyone for joining today. Like was mentioned, I'm Thilina Bandara, the Assistant Director at the Urban Public Health Network and the lead on this project.
And hi, my name is Mika Rathwell and I'm the Project Officer.
We'd like to acknowledge that we are both speaking to you from Treaty 6 territory and the homeland of the Métis. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship to one another. We're very excited to talk to you about our project around HPV immunizations called Solution to Increase Youth HPV Immunizations in Canada, a national quality improvement project. This is a bit of an outline of what we'll be talking about today. First, we will get into a little bit about who we are at the UPHN. We will then give a quick refresher on HPV, the vaccine, the generation of our project, some information about the state of immunization across the country, and more details about the project, as well as some preliminary findings. So a little bit about us at the UPHN. The Urban Public Health Network is a nonprofit organization founded by medical health officers. It started as a small group of MOHs who formed a group that wanted to share innovations across jurisdictions. We have since built up the research and project teams who are housed at the University of Saskatchewan. Our member medical health officers are from 23 large cities across Canada, from Vancouver to Halifax. And these members represent local public health units. Dr. Corey Neudorf is one of the members of the organization and is the current president. He's also a professor at the University of Saskatchewan, the current senior medical health officer of the Saskatchewan Health Authority, and he is the executive lead on this project. So let's jump into HPV.
Yeah, so before we get into the specifics of this project, I'm going to give a brief overview of what HPV is. So HPV stands for human papillomavirus. It is a common sexually transmitted viral infection. So it is spread most commonly through vaginal and anal sex. There are more than 100 varieties of HPV, over 30 of which are transmitted sexually. Upwards of 75% of people in Canada will have at least one HPV infection in their lifetime. So most people with HPV do not know they are infected and will never develop symptoms or health problems from it. Some people find out that they have HPV when they get genital warts. Some people may find out they have HPV when they get an abnormal pap test during cervical cancer screening. And others may only find out once they've developed more serious problems from HPV, such as cancers. So for most people, when HPV is contracted, it will clear on its own without intervention. However, when infection does persist, it can lead to cancer. Almost all cases of cervical cancer are caused by HPV. So each year in Canada, over 1,300 people are diagnosed with, and over 400 will die from cervical cancer. Cervical cancer accounts for 1.3% of all female cancers and 1.1% of female cancer deaths. Unlike most cancers, where incidence increases with age, a majority of cervical cancers are diagnosed in women under the age of 50, with the highest incidence being in the 30 to 59 age range. HPV is also associated with throat, anal, penile, vaginal, vulvar, and head and neck cancers. The COMPARE, so the Canadian Population Attributable Risk of Cancer Study, suggests that 5,300 cancer cases in Canada could be prevented by 2042 with increased uptake of the HPV vaccine. So across Canada, the HPV vaccine was first introduced between 2007 and 2009 for school-age girls, and between 2013 and 2017 for school-age boys, depending on the region. Available vaccines protect against either 2, 4, or 9 types of HPV, but each vaccine protects against HPV types 16 and 18, which are associated with 70% of all cervical cancers. In Canada, 3 vaccines have been approved, so that's Gardasil, Gardasil 9, and Cervarix. Currently, each province uses Gardasil 9, but in Quebec, the first dose is Gardasil 9 and the second is Cervarix. It is recommended that girls and boys are vaccinated before they become sexually active, so between grades 4 and 7. So this next slide is a table that we pulled from the Canadian Partnership Against Cancer's HPV Immunization for the Prevention of Cervical Cancer report that came out back in March of 2021. It outlines the year of implementation of the HPV immunization in school-based programs for students, along with what grade the vaccine is delivered in. So you can see that there was early adoption of the vaccine in Ontario and the Maritimes in 2007 for girls, and as early as 2013 in Prince Edward Island for boys. Most often, the vaccine is given in grade 6 or 7, but we do see it given early in Quebec in grade 4. And as mentioned before, it is given in these grades because it's recommended that young people are vaccinated prior to becoming sexually active. This next slide is from that same CPAC report, and it outlines the NACI recommendations for HPV immunization schedule. So for young, healthy, immunocompetent people 14 and younger, a 2 to 3 dose schedule is recommended. And across Canada, this is usually seen in a 2-dose schedule over 6 months in schools. Once you are over the age of 14, or if you have a weak immune system, this switches to a 3-dose schedule over 6 months. If you have missed receiving the vaccine at schools, there are catch-up programs that vary by province or territory. Continue on. So we created this map to give a snapshot of what HPV immunization uptake rates are currently in Canada, using the available 2017-2018 numbers. So as you can see, percentages range from 57.1% in the Northwest Territories and for boys in Ontario to 91% in Newfoundland. You also might notice there are gaps in data that is available, particularly in the territories and in some provinces for rates of boys. So when we're talking about HPV immunization uptake, it's important to frame it through an equity lens and discuss disparities in immunization rates and cervical cancer outcomes. The numbers I showed you in the previous slide can really only tell us so much. Across Canada, there's a lack of standardized data, which greatly impacts efforts to increase immunization rates across the country. So this can look like differences in how data is reported across provinces and territories that prevents direct comparison. As well, there's little data that has been collected on HPV immunization rates by demographic or socioeconomic data. We do know, for example, that women living in poverty have a higher prevalence of HPV infections, are more likely to be diagnosed with advanced cervical cancer, and are 30% less likely to survive a diagnosis. Additionally, First Nations, Inuit, and Métis peoples, people living in rural and remote communities, members of the LGBTQ2S community, and recent immigrants continue to experience higher rates of cervical cancer and poorer outcomes. So these unique barriers faced by Indigenous, immigrant and refugee, and low-income and minority populations must be addressed to increase uptake. In early 2020, the Canadian Partnership Against Cancer released their action plan for the elimination of cervical cancer in Canada from 2020 to 2030, which engaged partners across the country to work to eliminate cervical cancer by 2040. This advances a top priority of the Canadian strategy for cancer control to decrease the risk of people getting cancer. So in this strategy, the partnership laid out three priorities. The first priority is to improve HPV immunization rates. The partnership has set the ambitious goal of achieving 90% HPV vaccination of adolescents 17 years of age by 2025. The second priority is to implement HPV primary screening, and the third to improve follow-up of abnormal screening results. For the purpose of this project, we are working on that first priority.
So I'll talk a little bit about the generation of this project. So with priorities and strategy in mind, the partnership reached out to us, the Urban Public Health Network, as our members are medical leads of local units that develop and deploy HPV programming across Canada. Along with our partners at the Public Health Physicians of Canada, we're embarking on a project to essentially be CPAC's eyes and ears on the ground. We want to help focus CPAC's investment on improving HPV immunizations by providing them intelligence on the following. We want to know the state of HPV immunization data capacity, processes, sources, indicators, and variables across the country to understand sub-provincial HPV vaccination coverage rates and where there are pockets of under-immunization. Aside from the data piece, we also want to identify and assess interventions and innovative approaches and opportunities to increase HPV immunization in school-based programs. To do this, we plan to take a regional approach to leverage our connection with local public health units to place analysts across the country to collect the intelligence we need to answer our questions. The regional approach, however, has been difficult as COVID has decimated the capacity of public health to take on new non-COVID project funding. As much as regions want to participate and know that HPV is a priority, public health is simply too overwhelmed in many regions across the country to host an analyst or backfill current scientific personnel to tackle this issue in the near future. This is obviously understandable to our team, so we have primarily been trying to understand who and where this capacity to help unearth HPV-related insights lies. Once we started, however, we did find that there are opportunities. Number one, some regions were went into the pandemic already working on HPV. These right now include Alberta Health Services and INSPQ in Quebec. These two organizations have now created positions that are currently assessing our questions from within their health units. They're taking a look at the details, the sub-provincial HPV trends, as well as in-depth understanding on how HPV immunization programming really happens on the ground by reaching out to providers and communities where they can. These insights will provide rich portraits that will inform our recommendations to CPAC. We also designed the work to be as impactful as possible to the host organizations to yield real, actionable quality improvement information to improve local programming and decision-making. The other opportunity we're extremely excited about is the level of interest we're seeing from First Nations, Inuit, and Métis organizations from around the country, as many of them have expressed that cervical cancer is a major concern within their communities. We've doubled down on this interest and are building our team to engage these communities as we speak with the help of CPAC and their First Nations, Inuit, and Métis advisory circle that they have across their entire cancer strategy.
So as mentioned, this project uses mixed methods to determine barriers to HPV immunization uptake. So I've split this into a 3-step approach just to let everyone know. So step 1 is to collect HPV immunization data. So as Thilina said, we have placed or are in the process of placing analysts in local public health units to extract HPV immunization data at a sub-provincial, postal code, or school level where we can. So currently we have analysts placed in Alberta Health Services and INSPQ, and we are hoping for a few more in the new year. As well, we are working closely with First Nations, Métis, and Inuit organizations to determine data availability. This information will be compiled by central UPHN staff to compare across the country. Step 2 includes identifying pockets of underimmunization for these coverage rates. So using that local level data to identify unimmunized families and recruit caregivers of unimmunized children to take part in surveys and focus groups, as well as working closely with First Nations, Métis, and Inuit organizations to identify communities to engage with for survey focus groups and interviews. Step 3 will be determining barriers and facilitators to immunization. So that will be using survey, focus group, and interview methods to determine these barriers and facilitators at a local subpopulation level, and identifying and assessing interventions and innovative approaches to increase HPV immunization uptake. So we know that this work is being done in different areas across the country, and we want to shine a light on the things that are working. At the end, we'll be providing a report with recommendations to increase HPV vaccine uptake to the partnership for the next phase of the action plan, which is implementation.
So we're taking this opportunity to investigate some long-standing questions we've had as a research group regarding fundamentals to the public health systems in Canada. To investigate this, we have reviewed publicly available resources to assess basic functions and elements of systems by province. What we have found is that public health regimes are variable across the country in terms of capacity, that is analytic and frontline capacity, which have implications to their reporting and programmatic coverage of their populations. The variability is often dictated across urban and rural lines, which also have implications in specific reach of programs. This capacity issue has long been anecdotally well known for a while during routine periods and given public health's scope. But this has been highlighted very directly during the pandemic. This capacity issue is one that is going to have to be tackled in years, so Canadians are prepared to have enough people to carry out emergency and public health functions in any given situation. Practice is also variable in that program configurations may vary and integrations with other parts of the health system are idiosyncratic to each region. Governance arrangements are also quite different. Public health in some places exists within health authorities, sometimes within municipalities. There are also sometimes semi-independent agencies like BCCD's Public Health Ontario. Different governance arrangements allow for different levels of influence and decision-making in a given jurisdiction. Lastly, there are still open questions about continuity of leadership in public health systems. To what degree are programs led by medical health? What are their roles? And what are the roles of the administrative dyads they work with? What are the implications of different public health acts on public health leadership in each province? These all have profound implications on what can even be done to improve HPV immunization rates in their own. Being clear about the contextual factors that exist across the country can help sharpen recommendations to be feasible across the country. Some preliminary findings from our analysts suggest the following. HPV programming is dependent on the population geographic characteristics of the given jurisdiction. That is, for example, the existence of local health centers in smaller communities may have more uptake than in the school-based program, for example. These differences matter when designing targeted investments to improve coverage rates. Data capture and availability is highly variable as well. This is not a surprise given the poor state of immunization data systems across the country, many unique and often incomprehensible to each other across provinces. Thirdly, everyone is catching up on HPV due to COVID. And this again is dependent on resources and the COVID waves that jurisdictions are in any given point in time. Community trust is key for uptake. This is likely true across a number of public health activities, and this is coming up a lot as HPV is not only a cancer-preventing immunization, it has also profound sexual and gendered health dimensions to consider. The fact that it is a primarily school-based as well emphasizes the need for trust between parents, providers, and paper-based consent is a barrier for participation for obvious reasons, and we'll be bringing that. And education is often cited as a key driver for HPV uptake.
As Thilina mentioned, we quickly recognized in this project that COVID-19 was having a large impact on the capacity of public health officials to engage in the work, but also disrupted vaccination programming across the country in 2020, when full cohorts of kids missed their immunization due to school closures. In October of 2021, we held a roundtable for UPHN members and their delegates, which included MOHs and immunization specialists from across the country to discuss disruptions to HPV immunizations due to COVID-19. It was moderated by Dr. Elizabeth Dyke. It was a great conversation with lots of really insightful comments and recommendations for the future. So to give you an idea of what was discussed and learned at the roundtable, I've split the conversation into 3 topics. The first being barriers to HPV immunization that were seen prior to COVID. This included moral issues around HPV vaccine and its association with sexual health, parents who felt their child was too young to be receiving the vaccine and could lead to sexual activity at a younger age, the newness of the vaccine. Because the vaccine was introduced in 2007, some parents see the vaccine as too new with not enough research to support its use. One participant felt that one challenge may be the need to build parents' trust on the vaccine's safety and effectiveness, which leads to the next point. There's an inability to discuss the vaccine with parents because vaccines are given at school. There's no interface with the doctors, nurses, and parents who are key to vaccine decision-making for youth. Parents are sent home with an information sheet for several vaccines, and if they do not consent to vaccination, there's often no follow-up. The number of doses. If a child misses their second dose, they may have to start the series again with a 3-dose schedule if they're over the age of 14, which can be a large barrier. A lack of resources. School immunizations are resource intensive and there can be staffing issues. Participants noted that while it would be beneficial to have staff calling parents who do not sign the consent form, this often isn't attainable. And issues with inequity for specific populations were mentioned, such as language barriers with newcomer populations and lack of trust in medical professionals in Indigenous communities. The second topic discussed was what happened during the COVID-19 pandemic in regards to HPV immunization. Attendees noted that full cohorts of students missed vaccination due to school closures in 2020. While some areas in the country have been able to catch up, others have not. During this time, there was a large strain on public health. and the COVID vaccine and early childhood vaccines were often prioritized. As well, attendees mentioned that with vaccine misinformation rampant, they have seen this bleed over into HPV and other vaccines. The third topic discussed was opportunities to catch up, and not only catch up those missed cohorts, but just to increase uptake in general. So the first was a focus on cancer prevention. This could include working with cancer registries to frame HPV as cancer prevention for parents to help address the moral issues. To build on lessons learned from COVID-19, this could include building stronger relationships with schools that occurred during COVID, and using the data that emerged during COVID regarding vaccine inequity to target specific groups. Personalized and electronic consent process. As Thilina mentioned, paper consent is a huge barrier. Moving to electronic processes and a more personalized approach, as HPV is often part of a package with several other vaccines. To work with peer ambassadors and other health professionals. So this could include community members who champion the cause, community health workers who are trusted, gynecologists, sexual health centers, pharmacists, working together to address gaps in immunization. And education sessions with parents. So building relationships with parents through offering HPV education sessions or having conversations with parents who have questions when reviewing the consent forms was viewed as critical to encourage HPV vaccine uptake. There was agreement that more effort and time could be put in place to follow up on HPV vaccination, as is done for infant immunization.
Upon starting this project, turns out many organizations were interested in this question, including CIHR, received proposals to understand the impact of COVID on children and youth. We parlayed this opportunity to develop a proposal, sort of spin-off research project to understand the impact of COVID on school-based immunizations in general. This leads us to our one-year project titled Assessing the Impact of COVID-19 on Routine School-Based Immunizations and Investigating Strategies to Catch Up on Missed Immunization Opportunities in Canada. In short, the objectives of this project is to document the scope of the impact of COVID on school-based immunizations under multiple levels of health system catch-up. Our team includes researchers and knowledge users from Saskatchewan, Quebec, and Alberta. We're going to accomplish this through 3 pillars of work. Number 1, we're going to use historical provincial level immunization information. We're going to test the feasibility of modeling cervical cancer outcomes, whooping cough outcomes, and hepatitis B burden within the cohort of youth that missed these immunizations in 2020. Number 2, we're going to leverage our UPHN network to survey MOH, medical officers of health, on the disruptions and recovery plans. And lastly, we're going to conduct 3 in-depth case studies in Alberta, Quebec, and Saskatchewan to develop richer policy timelines, unearth deeper provider perspectives, and learn lessons on public health program development in this space. So what needs to happen to improve immunization rates? We'll give you our sort of preliminary 30,000-foot results on this right now. It's clear, and it has been for a while, that we need a national immunization registry to have a true understanding of what and where we are even covering populations with immunizations. Number 2, we need a better system to share local practice innovations in a way that doesn't necessarily rely on projects, but have an ongoing routine way to share innovations at a local level. Number 3, HPV immunization needs to be better integrated across the continuum of care, from public health to primary care to even oncology. We can't let people fall through the cracks after school-based eligibility is over. And we're hearing this a lot from our from early conversations we're having with folks. And when folks fall out of eligibility, is too high, up to $800 out of pocket. This has been coming up over and over again in many jurisdictions. This informs the clear ask of many communities to increase eligibility overall. Like I mentioned before, we need lower friction consent methods for parents and caregivers, perhaps electronic and more personalized. There needs to be an increased level of dedication to resourcing school-based public health programming in general. Again, this is workload and capacity, again, play into this. And finally, we need to consider other needs-based approaches that consider, number one, the legacy of residential schools for First Nations, Inuit, and Métis communities, especially around a school-based medical intervention, like a school-based immunization. And we need higher touch education programming for cultural and language-based needs to ensure caregivers have the information required to make an informed decision going forward. So thanks a lot, everyone. Again, we're out here just gathering and doing a lot of listening, and so we'd be very happy for any of the experts that are in attendance right now to reach out to us. This is our contact information. Thanks again.
Right. Thank you, Dr. Bandara and Mika, for the wonderful presentation. At this point, if you have questions, please submit them using the Q&A feature. As a reminder to everyone, you can also submit your questions anonymously. Any questions that are answered live will appear in your Q&A window under the All Questions tab. Also, please note that the webinar is being recorded and will be shared with all attendees after the presentation. Presentation slides will also be shared. So we have one question. Yeah, so please only send us topic-related questions through the Q&A box. We'll give a few more minutes for those who are typing to type in their questions and submit them in the Q&A box. So while we're waiting for the attendees to type in their questions, is there anything else that the presenters would like to add to the presentation at this point? Yeah.
No, nothing right now. Just know that we are very happy to listen to everyone's ideas about HPV immunization. That's why we're here. If you ever had something that you've wanted to tell CPAC or a big funder that is looking to invest in this topic, please let us know. We'd love to take it to CPAC.
Okay, so we have 3 questions here. So first one is, could you elaborate on ways in which more personalized consent forms can be used for parents? I'm also curious about your thoughts on educational programs for cultural or language-based groups.
Sure, yeah. So this is something that we heard from folks, the personalized consent forms. They didn't necessarily say that the consent forms might be more personalized, but at least giving an opportunity for folks who are reached out through a consent form to reach out to somebody that can answer their questions in a one-on-one basis. So what we imagine is something to do in the consent form would be the contact information of someone who would be dedicated to answer those questions for parents. Let me take a look at the question here. There's a second part. Also curious about thoughts on education programs for cultural and language-based groups. Yeah, so this is because the nations are based in schools. I think this kind of more targeted education programs for cultural and language-based groups could be developed through that collaboration with the schools. So I think the schools know best and where those where their patients, in which ways their students best learn, and if there's cultural and language-based programming that the school already conducts, there could be a great opportunity for collaboration between public health and folks in education to integrate some of this public health language or public health information into their cultural and language-based programming.
Okay, thank you. So our second question is, do you know how Canadian rates of vaccine vary from other countries such as Australia that routinely vaccinated boys much earlier than Canada?
Great question. I don't know. This is something I'm sure that CPAC has looked into, but right now we haven't done any international comparisons. Mm-hmm. But that is a good piece of information that we might have to include into our report. Yeah.
I think the second question is also a follow-up. I think there's important conversation around implications of vaccination in men. Any insight or elaboration on this topic?
Yeah, we've heard this come up from a couple places that have a proportionately high group of male service population. And this ties into sort of what we're talking about earlier about the gender dimension of communicating about HPV. There hasn't nearly been enough communication around the cancer risk. I think that wasn't rolled up at the same sort of level of intensity as it was with girls when the immunization was first introduced. And so the introduction into boys is more recent. So I think that's definitely an opportunity area for local public health as well as cancer agencies, right? And this speaks to more of the collaboration that could happen between public health and cancer agencies.
Okay. Next question is, thank you very much for this presentation. Very helpful. Your results show that building trust is very important. Do you find ways to build trust between parents and healthcare providers?
Yeah, so some of the work that was, this is an issue that shows up in many immunization programs, not just youth immunization, but also this shows up in childhood immunization between public health, having children immunized. What's shown some success in systematic reviews as well as individual studies, even a study that happened in Saskatoon, is that trust can be built by engaging parents through a trusted sort of community liaison type of person that's hired within public health to go out and do outreach with parents. So comfortable, they have someone who's sort of a touchstone in their community trust that they can get information through, that public health can work through. And so, I mean, that's one way we've heard also around this project in remote and rural communities, especially.
Right.
And again, more communication between public health folks and parents through consent process might give that opportunity to talk to parents one-on-one. I don't know, Mika, if there's anything else that has come up around that topic.
No, I think that's kind of exactly what we're hearing and seeing as we work with lots of First Nations and UMAT groups, is that they use community champion models where community members who, the cause might be near and dear to them, go out into the community, work with community members to increase vaccination rates or whatever health issue they're working on at the moment.
Okay. So the next question is, Can you say more about the shift from cervical cancer screening to HPV screening?
Yeah, so I wish we could. We're kind of, you know, we're very focused on the immunization pillar, but we have been running into more and more of the folks on the screening. So there's sort of three pillars of work going on simultaneously to, you know, in service of this larger cervical cancer reduction strategy.
Right.
And so there's the immunization, the screening, and the treatment. And so we're very focused on immunization, but we do keep running into folks because the immunization conversation happens a lot in those more downstream pillars of work from that other organizations are taking part in. So we get to hear when folks down into treatment are saying, we do treatment on cervical cancer and that's what we do, but we would love to, once we get an abnormal test, we would love to be able to immunize. Like, how do we get this immunization conversation throughout the whole spectrum? So that's kind of how we've been approached on this topic, and we get to hear a little bit about the screening. We do know that there is some pilot smaller projects happening in a couple of provinces where they are doing mail out sort of self-testing kits for folks. So they don't have to come into the clinic and do the HPV screening as it is right now, but more of a self-tested swab where they can test for HPV. And so those projects have reached out to us and want to work together on connecting folks for when those pilots make their way through their program to connect them back to public health if they haven't been immunized, so we can folks that way.
Okay, sounds interesting. So the next question is, how can we follow your work? Do you have an idea of when and where your publications and reports will be available? This is a very interesting project.
Yeah, so we're sort of thinking this through right now. We've to best communicate what's going on. I think the best way would be just to email us, and we can let you know what we can when things come around. We'd love to develop some sort of ongoing communication through maybe a newsletter or something like that. But we're still trying to figure out exactly how to do that. We're still sort of in the information gathering phase. But for sure, the project ends around sort of March 2023, which is when we'll be tying in our communications with what CPAC will be communicating on this project as well. And so what I would say is, yeah, please send us your email and we can make sure to keep you in the loop where we can.
So our last question is, please be very careful about swapping the word sex with gender. How can HPV information be shared with young women with intact cervixes who identify as men?
Yeah, so I think this is where sexual health clinics can really be leveraged as a place where more information can go and there can be an increased level of interface between youth, who may not want to go to primary care to talk about this, but maybe in a more LGBTQ sort of safe place that a lot of sexual health clinics are. Mika, can you speak to this a little bit?
Yeah, that's a great comment, and it's something I've been thinking about more and more because a lot of HPV information that's out there is very gendered. So how do you make it more inclusive? And that's one area of the project I'd love to explore further, and maybe something the new year is kind of speaking with people who are doing that work across the country and learning from them as well.
Great. Okay, so that's all for our question and answers period. We do have a few more minutes left for questions. If anyone has any questions, please feel free to type them in the Q&A box. We have about 5 minutes left for questions. Alrighty, it seems that we have no more questions. So if you have any questions for Dr. Bandara and Mika after the webinar, please contact at canvax@cpha.ca, and we would be happy to connect you with them. So thank you all for attending today's webinar, and thank you again, Dr. Bandara and Mika, for the wonderful presentation.
Thanks, everyone.
Yeah, thanks for having us.
So as a quick reminder to everyone, please don't forget to fill out the survey upon closing the webinar window on your device. We look forward to your feedback so that we can make improvements based on your suggestions. Thank you and have a wonderful afternoon and stay safe.